Thank you, Dr. Pullatt. So it's my true honor and privilege to introduce our next speaker, Dr. Patricia Numann, and she's the past president of the American College of Surgeons from 2011 to 2012. But more importantly, she's a compassionate surgeon and an awesome mentor. And she's a distinguished endocrine and breast surgeon. She practices in Upstate New York, and importantly, based on an awesome work that she has done, in fact, they renamed the center as Patricia J. Numann Breast and Endocrine Surgery Center. Not too many people get that much honor. So that explains, in a nutshell, the impact that she has had in the community, and it's truly my privilege to have her on board. Thank you.
It's always great not to be first, because somebody else has had to deal with the IT parts of the program. But yeah, that was a wonderful presentation, and it reminded me of some of my early career, not such easy memories of doing those operations. I wish we had your technique back then. It would have been much better life. But anyway, thank you. So President Nazir, President Tabitha, and fellows and guests, I am really deeply appreciative of being an honorary fellow of the International College of Surgeons. I've made so many friends. I've seen the work that you do. It's wonderful, and it is really transformative in local surgery. So it's great to be a part of this wonderful organization. Thank you for inviting me to share my thoughts with you on moving through our professional lives. I have no financial disclosures. Go in the right direction there. I have no financial disclosures. Most of us, particularly in academic surgery, move through many changes in our interests and our career, and often play many roles at the same time. This career cycle from the University of Baltimore is a useful way of thinking about how we progress in our career. Most of us repeat this cycle often. We initially discover we want to be surgeons, then decide on our particular specialty, practice setting, and location, then establish our career. We don't always get it right. Frequently, we have so focused on our course of action that we committed to, sometimes because of parental expectations and sometimes because of preconceived notions of what we should do. With time, we learn more about ourselves, what interests us, what we want to learn more about, and what makes us happy, and what fits with the lifestyle that we like. You often find that you need to compromise and prioritize. For example, I really don't like to get up early in the morning, but I love surgery, and so in order to have a fairly organized practice, I realized that I had to do the first case of the day, so I managed to get up early. Whereas one of my colleagues who didn't like to get up early always had cases to follow. So you do what you need to do to sort of accommodate your lifestyle. You sometimes think you need to do something, but then find it is always last on your list. I found this with basic research. As an academic surgeon in the 1970s, you need to do basic research. So I decided that I would have a lab, and I even got peer-reviewed funding, but boy did I hate killing rats, and I was even allergic to them. I figured 10 years was a good try, and I proved I could do it. So when my PhD decided to move, I took the opportunity to close my lab. I gave the research money back, which really shocked them, and decided to pursue surgical education, which I found I loved as my academic career. And in 1980, when I did that, I was told I might just as well have leave academic surgery, as I had ended my academic career. Instead, I was part of the formation of the Association for Surgical Education and helped make surgical education a viable academic career, not only for me, but for many. If we are lucky, we live long and have a long career. Likely your interests will change as you age. New things come along and stuff happens as you need to change course. I changed course many times. I came to medical school to be a family doctor or neurologist based on my father and sister's illnesses. But when I was a third-year medical student, my mother became ill. After a number of doctors did not seem to know what the matter was, she saw a surgeon who diagnosed her pancreatic cancer. Remember, back then we didn't have CT scanners. Those surgeons were just the best doctors I had ever seen, even in medical school. So I changed course and decided to become a surgeon. You don't really have time to hear what an ordeal it was for a woman to get surgical residency in those days, but I am very stubborn. I had not planned on academic surgery, but the group that offered me a private practice spot had to rescind it when a person they had earlier recruited, fortunately, came back from Vietnam. I quickly got a job, a part-time job at the VA, so I could have a paycheck, which was important. I liked teaching, and they liked me. We had gotten a new chair. He offered me a job in the department, which became my academic career. I found that often I had 2 or more activity streams going at a given time. And this is actually a good idea. It's really pretty risky to be a one-trick pony. When one thing may not be going as well as you like it, it is great to have some other things to cheer you up. So when my chair kept firing me, my national work gave me great solace and great support. Being a surgeon, though, is always my constant. I travel a lot, and I am often asked, what is my favorite place? The OR is always my answer. With each phase of my career, I found I had to invest in myself and learn more home skills. When I began in 1970, an academic career did mean basic science and research. I learned how, I got their funding, but when my PhD decided to leave, I decided that it was time for me to make a change. And I realized that I had to make myself do the research, that I really didn't like to do it. But I knew in those days that if I wanted to get promoted, if I wanted to get tenure, I had to do basic research. And that really annoyed me. And so when I decided to leave, I not only made education my academic career, but I worked to change the promotion system in our institution so that you could be promoted for your educational activities and your clinical excellence. And that system still today exists in my institution. When I was thrust into running the program when another faculty left, I was not sure it would work, but I then decided if I was going to do it, I would do it well. I felt that the exams we got were often unfair, so I decided to be an expert in testing. I felt strongly that if you want to be considered an expert, you should develop significant special skill in that area. And there are many ways to get these skills. The Association for Surgical Education, the Program Directors Society, Surgeons as Educators course at the American College of Surgeons. You can get an MME, a Master's in Medical Education, or you can get on a committee like CSABBAGH or the national boards, and they will teach you to be a really great test maker and creator and a good surgical educator. I like teaching and all that it encompassed so much better than the lab research. When running the student course and becoming involved in national organizations, I found that I liked running things. As a woman surgeon in those days, I was pretty visible, but also often the target of bias. So I was always aware that I really needed to be very good at what I was doing. I learned to conduct meetings and took courses in administration. One of the best courses I ever took was on learning how to deal with difficult people. I would strongly advise it, as there are an abundance of difficult people that we must all deal with. So I would encourage you, as you plot your course, that you look at what can benefit you and invest in yourself. Figure out how you learn best and what will help you. I learn well by reading and old-fashioned studying. I like attending workshops where I can discuss thoughts with others and get new ideas. After each conference, I look to implement one of those ideas in my own practice. And I hope each of you, as you leave this meeting, will look at how you can implement things you learned here in your own life, in your own practice. I love meeting people I admire. My chair had a practice of asking who we wanted to meet when we were at a meeting with them. And it was really wonderful. Many of those surgeons made my day. Just meeting them, getting to know them, to be able to say that I knew them, that it was just wonderful because I always admired them. And I try to always do that when I bring people to meetings and when I go to meetings. I think it's important. I also always try and connect people who I think would enjoy knowing one another. Frequently, these lead to long-term collaborations. Bringing younger faculty to meetings, or if you are younger, learning to get along well is very important. I would study my heroes, and I would learn at what they did and how they behaved, and look at how they behaved, and try to emulate their behavior. There were people I would go to for advice. Now they are called mentors. You need to develop those. It is rare that a more senior person will think you are just so wonderful and so special that they spontaneously reach out to you to help you and to guide your career. But you can develop that relationship with them. You can help them in their work. You can ask to work on a project with them. You can help them make their clinical care go more easily. You can ask them for advice. And you can nominate them for things and nominate them for awards. There are so many ways that you can be helpful and make yourself noticed. Any expert will tell you that practice makes perfect. So whatever it is you choose to do, find a way to practice. Whether it be speaking or teaching or doing a particular surgical procedure, the better you are, the more successful you will be. Perhaps most surprising to me was how the better you were and the further up the ladder you climbed, the more people wanted to tear you down, discredit you, and destroy you. So you need to develop a thick skin if you don't already have one. Most people who survive a surgical residency already have it. So you're in pretty good shape. Make sure that you always have people who really unconditionally love you. They can be either in your professional or personal life, but it really helps when things are tough to have people that you know you can go to that will really be supportive. And if you're fortunate, you'll have them both in your personal and your professional life. But it takes work to develop those relationships, so make sure that you work to develop them. It is very important to explore opportunities at every phase of their career. You may be surprised at what makes you feel fulfilled and happy. I actually had somebody tell me that they enjoyed fundraising. It's hard for me to fathom that, but people do enjoy different things, and so we see what really excites you. And at each level of your career, you have the ability to explore so many opportunities. I advise students and residents to be sure to look around. Some seem to get so focused only to realize that they need something more or different. It is never too late to change or to add something to your career that excites you and that you wish to explore. But be careful not to burn bridges. The worst thing that you can do is when you leave a job, tell the person that you're leaving how terrible they were and how badly they did their job. Not a good move. Also realize that as time passes, new opportunities arise, new techniques develop, new areas of interest. View change as an opportunity, not as an annoyance. Once you settle on an area of interest, get out to work. People are not mind readers, and most of us are busy with our own lives, so we really don't pay a whole lot of attention to what others are doing and what seems to be interesting them. So ask to be on communities or join research groups. Now most organizations actually allow you to self-nominate, and if you are interested in doing something, do self-nominate and do look for that position. I have always found that being useful gives one a great advantage. So be active in organizations you join. Volunteer, help in projects, and you will be noticed and recruited for more meaningful roles. Don't wait to be asked. If you see something that needs doing, do it. As the saying goes, it is better to seek forgiveness than wait for an invitation. A few additional words of advice. If you say you are going to do something, do it. For me, the more I dread the job, the sooner I try and get it done. When you can be counted on to do a great job, you are valuable. Have the courage to always do what you believe is the right thing for the situation, which may not necessarily seem like the best thing for you. I gave up my ideal parking space as I believed it should be for the disabled. Of course, when I saw a colleague's kid put up the disabled sticker and run out of the car, I bet my colleague got a good piece of my mind. Which brings me to moral courage. Moral courage is not easy to come by, but people with courage who stand up for what they believe in are those we trust. Even if we do not necessarily believe the same thing, we respect them and we trust them. I have always preferred to know where people stand and have to guess, or worse yet, be misled. With moral courage, you need to act in a way that demonstrates your belief, and you need to be consistent in your message. For me, my advocacy for women surgeons has sometimes been challenging, particularly in the beginning when there were few. When inappropriate things were said about women or misinformation given, you could always count on me to stand up and be heard. Not just when it was convenient, but when the person who was saying it was somebody that you could easily challenge. Another piece of advice relates to change. In general, we are adverse to change. But if you look at change as an opportunity, you may find a new direction that you love. We've heard about that. Minimally invasive surgery, robotic surgery, public insurance programs, AI, and environmentally good ORs are some more recent areas that give great opportunities. Always be positive. More people want to work with people who are happy and positive. Remember, happiness is a choice. Your attitude matters. No one wants the person who complains when you give them $1 million that you gave it to them in $100 bills. Always prepare for the future, as whether we like it or not, things do change and we change. There are many ways to prepare for change. So if you think you want to be a chair or division chief, you may benefit from getting an MBA because most chairs are fired because of fiscal and money mismanagement. Being able to read a spreadsheet and report return on investment can go a long way in helping you with your work. So many people come with ideas but no business plan, or with a problem but no idea of the solution or willingness to participate in that solution. My stance was always, do not bring me a problem without bringing a logical solution and a commitment to see it through. Funny how fewer and fewer people came with ridiculous problems. Always bring a business plan with any request or proposal. Don't have to be asked for it. It will get you much further than just bringing an idea. There is an organization for physician executives that has excellent courses. There are many departments that have excellent courses, medical universities who put together leadership courses. And even the AAMC has a wonderful course on management and academic careers. And many of these will be funded by your own university. And you may want to develop special skills in things like coding and quality assurance, become an ATLS or a SABBAGH instructor. If you want to be on the speaker circuit or in a position where public speaking is important, look at the feedback you get when you speak. Practice giving your presentation out loud. Time yourself. Ask someone to listen and critique you, and if needed, take a public speaking course such as Toastmasters. Join organizations that will put you in touch with people who you admire and can help you. If you want a big, successful practice or career, the contacts you make, even playing golf, tennis, basketball, may open doors as can belonging to country clubs or benevolent groups such as the Rotary, Scouts, Lions Clubs, organizations of that sort, as well as organizations like this. Always keep in mind that things are going to change, and with any luck, you are going to get older. As you are moving on, be sure to bring others along with you. When you cannot or do not want a job, recommend someone who does. When you have a chance to nominate a person for a job or an award, do. Keep your list of worthy people so you have a name on the tip of your tongue. One of my chair friends kept a list of people in his pocket that he would recruit to come to his institution. I never went there, we're still friends. You will be surprised at the positive return you get from helping others and recognizing others. I think I got ahead of myself here, because that's how it works. All right. There's just something. I went through these before, there it is. Okay. I couldn't cover the subject without speaking a bit about the serendipitous events that can change your life. You may even think me a hypocrite to address this topic, as many of my best experiences were serendipitous. When a resident, I always planned on going into private practice, but as I said, that did not work out. Fortunately, I could work at the VA, and incidentally, even though that was a fallback job, I love working at the VA. and continued a part-time position my entire career. It is a great job when you want to take periods of time off and have a more orderly life. As it turned out, we had the new chair who liked me, and we had very few faculty at that time. Medicare had just come into existence, so it gave me a great opportunity to develop my academic career. A few years later, the dean, who was an ENT surgeon, had worked with me and recruited me to the associate team. I had no idea what that really entailed or whether it was in my skill set, but I figured I could learn and try it out because it sounded interesting. I recommend that approach if the job sounds interesting. Take it and see if you can get the skills, and you frequently can. That's a thing that men are more likely to do than women, so it's one of the things I encourage women to do. Even if you haven't done that before, if you think you can do it, you want to do it, go for it. One day I got a call from an orthopedic surgeon in Philadelphia asking me if I would run for a seat on the Council on Scientific Affairs of the AMA. I said I had never been to an AMA meeting and did not know what the council was. He explained, it sounded interesting. I said I would talk to a colleague who was very involved in the AMA, and he encouraged me. Was running for that position ever an experience? It's a long story, but you have to go with hats and on and on. It was very interesting, but I'm very competitive, and so of course I got the position. But as a member of that committee, I was able to help pass the Bariatric Quality Assurance Act. I became a member of the Human Genome Project and sat on the ethics committee that decided we couldn't genetically test children unless it would benefit them as a child. And I got elected to the American Board of Surgery, which allowed me to have a very important role in surgical training, and I became chair of the board. So you never know. I also learned that being unique can have its advantages. I was the only visible woman in many settings. I looked at the positive side in the term the women don't belong, can't do it reverent, into advocacy instead of anger. I made good friends in the organizations I belong to, and they have been a blessing. Your friends are really your treasures, and your colleagues are your treasures, so always treat them that way. And so if you get a strange offer, give it a really good look. It may be right for you. And when you do have unique qualities, take advantage of them. Always look to the future. Because if you will have another phase of life, and I planned my retirement very carefully, to the point that I even had a comeback for what will you do when you retire? My answer, I am going to Timbuktu. Stop and hold. And I did go, it was wonderful. But don't close doors. I still get offers. I still am employed and get a paycheck now for 72 consecutive years. At age 4, I still have goals and plans, and most important, being to remain cognizant, ambulatory, and relevant. I hope each of you has the wonderful career that I have had, and thank you for the honor of presenting my thoughts to you.
Thank you, Dr. Numann, for your words of wisdom. Your words were not a roadmap, I think it's a compass. And you have left a legacy and continue to inspire the generations. With this, I'd like to invite Dr. Deep Shabbas Memorial Lecture on Media, Arcuate, Ligament Release, Technical Course by Dr. Rana Pullatt. Rana Pullatt is a professor of surgery at the MUSC, where he serves as Director of Bariatric Robotic Surgery and is also the Division Chief of Foregut Surgery. His specialization is operative Foregut and Bariatric Surgery and pioneered laparoscopy and single anastomosis dual switch procedures in South Carolina. Dr. Pullatt also directs a robotic surgery training program for general surgery residents and serves as the Director of Bariatric Surgery for at Ralph H. Johnson Center. Dr. Pullatt, thank you very much.
While he's setting up, thank you, Dr. Numann, for that amazing talk. I still do maintain my VA privileges. I have an appointment in the VA, and many years ago, about 15 years ago, I started a VA program for bariatric surgery, and we serve veterans from South Carolina, Georgia, and Alabama. Oh, thank you, Sharif, for the privilege of the podium. Thank you to the International College of Surgeons for the invitation. It's my pleasure to be here. I'm going to talk about median Arcuate ligament syndrome. These are patients along with gastroparesis who are completely labeled as crazy, and there might be some pathology there, but if you carefully select these patients, these are some of the most gratifying cases. I do want to acknowledge my chair, Dr. Baliga, who taught me the anatomy of that area doing donor runs in 2001. So I did a liver and kidney transplant surgery fellowship, and so I'm a bit more familiar with that area. These are my disclosures. I am a consultant for Intuitive. I helped with developing their robotic product. I also consulted on with Medtronic about their Hugo robot, and I have spoken in the past for Combat. So MALS, otherwise known as Dunbar syndrome for the junior residents in the audience. First, it was seen as an anatomical fact by Lipschitz in a 1917 report, saying that there's reports of compression of celiac artery on dissected human cadaver specimens. As a clinical entity, it was described in a series by Herjola in 1963 first, and then a study was done in 1965. The typical triad is postprandial pediatric pain, drury, and weight loss. So MALS is a disease of exclusion, and you have to really extensively work up these patients before committing them to a really extensive surgery. And you have to rule out the low-hanging fruits like bone bladder surgery before putting the patient through MALS. Typically, there's a lot of functional GI patients floating around, and most of the times you'll get a patient referred to your clinic if you take this patient population on that is a completely functional GI patient. Incidentally, oh by the way, in my 10th ER visit, they ordered a CT scan and there was a hook deformity and they referred me to your clinic. And you know, that patient could have IBS, that patient could have a lot of other pathology. So it's very important to rule out other pathology, and some of the tests that you use include the CT scan, which CT angio, which shows a hook deformity, as you'll see in this, where you see the classic hook, and this differentiates it from atherosclerotic disease, because in atherosclerotic disease too you can have narrowing of the celiac artery, but the hook deformity is absent in people with atherosclerosis. So now this is thought to be because of lower insertion of diaphragm or an upper origin of celiac artery. There's still kind of difficulty figuring out what it is. So this is kind of a dynamic MRA or dynamic CT study. This is what you see. In deep expiration, the hook deformity becomes more deformed. The diaphragm pulls against these ligaments and causes a decrease in flow through the artery. We know that these patients are compensated well by the SMA, so it's not ultimately a blood flow issue. However, there are reports that in MALS patients who have this classic deformity, there's increased amount of splanchnic aneurysms. So aneurysms of the pancreaticoduodenal arcade, which can potentially rupture. So this is something to note. The classic or the most easy study would be to get a duplex ultrasound, especially looking for variations of the peak systolic velocity during exploration. That's about the best test that you can do, short of doing a dynamic MRA, which is a lot more expensive and difficult to do. So the ultrasonic criteria include a peak systolic velocity greater than 350 is like absolutely yes, but it could be a dynamic change in the peak systolic velocity, which is very significant. So it doesn't have to be 350. It could be 300, but if you have a change of almost a delta, which is quite great, then that patient probably has significant compression of their celiac artery. The distraction angle of the celiac artery to the aorta of greater than 50%. It's very 83% sensitive, and there's a 100% positive predictive value. All of this occurs along with the clinical criteria. So typically, I used to do these laparoscopically, and they are a difficult operation to do. There are a few things that I think in my hands. I did a lot of laparoscopic SABBAGH and duodenal switches before switching on to the robotic platform. So there's probably 3 operations that I think in my hands the robot is far superior. And one is the mouse surgery, 2 is type 3, type 4 hypohernia, and 3rd is a very high BMI patient for a duodenal switch of SABBAGH. So in this operation, what you essentially are doing is not just do the release of the ligament, but an extensive neurolysis of those nerves around the celiac artery. So that's very, very important you do that, because if you don't do that, there's possibility that these patients will have pain. So you go find the median arcuate ligament, divide it, and usually we use a hook. So this is, for example, a typical approach of these surgeries. You find the left gastric vein, dissect the left gastric vein, take the node of the hepatic artery, loop around the left gastric vein. If the vein is draping around, you can ligate the left gastric vein, and then basically find the left gastric artery and the hepatic artery. And once you find that, you find the takeoff of the celiac artery from that bifurcation, and then work your way backwards. This is probably the most economical, time-economical way of doing it, is to find the left gastric artery and the hepatic artery, and then work your way backwards. In this case, the left gastric vein was draping over the artery, and I think in this case we decided to clip it. But here you have the left gastric artery, and you start taking all of this areolar and nerve tissue around that entire plexus. Not doing a good neurolysis around this will really kind of impede you. So the difficulty for our students here is that celiac plexus really drapes around the artery, and sometimes it's very hard to differentiate between that and the artery itself. And laparoscopically, it's a little bit harder. So in this case, we decided to take the vein, and then now you have the celiac, now you have the left gastric artery and the celiac ganglion fibers. You can see those thickened fibers that are being taken right off that. And I think not doing this step and just concentrating on the mouse is not going to really help this patient. So an extensive neurolysis is very important in these patients. If you're not going to do this, then it's not truly a mouse operation, because I think a lot of this pathology is from the nerve compression itself. So you can see the celiac ganglion being removed from that area and being burnt and taken out. So you got to be really careful, obviously, because it's a very high risk area, and really need to be meticulous about this. So now you're beginning to see the hepatic artery, you see the splenic artery, and then you have the left gastric artery. And then using that traction to the patient's left leg on the left gastric artery really helps expose the celiac, because the celiac dives down into the aorta. And so you got to be really watchful of that angle. It's a very acute angle that dives down. So you're hooking into that, and then basically again, you can see me doing all of the neurolysis around it. That's the most important part. And there's the ligament coming into view. So it's a tight, fibrous band that compresses the origin of the celiac artery. And you'll see me show this thing. So once you see this, you see that tendinous, tight band, and that's your mal. That's your median arcuate ligament. And it's pretty significant, and it's pretty taut. And once you take that, you release your the celiac artery. So there's the mal being taken, and then you work backwards, and you will see the aorta show itself. So this is the most economical way of doing this operation without destroying the crura, without taking a hiatus down. So you're not working all that, you're just working on your way backwards from the left gastric artery down into the aorta. And so now you have a beautiful exposure of that. So you can see pretty extensive neurolysis as well as the origin is clearly seen. So sometimes you can have the inferior phrenic arteries coming a little bit more anteriorly, or the celiac artery coursing in a little bit more tortuous fashion, which makes this dissection harder. So this is another way of doing it, is not just to fall back on the thing. So if somebody has higher visceral obesity like this patient, and has this issue, then potentially the safer option would be to find your aorta first. This is the node around the hepatic artery being dissected and removed. So that gives the exposure to the left gastric artery. So you can see the left gastric artery there. And you have to do a little bit of defatting in this area. And this is what happens when somebody even has a little bit of increased visceral obesity. This operation becomes a lot more challenging, a lot more difficult to do. So in these cases, I go and find the aorta first, and then find a target area for me to work. So I'm just taking some of these nerve fibers, and then looping around the left gastric artery. So that's the left gastric artery right there. I'm just dissecting around. Sometimes you get into a little bit of bleeding. You can control that with a bipolar. And then I have an assist port that's suctioning. So that's a Maryland bipolar being used to kind of come around the left gastric artery and then pull it downwards. And now what I'll do in this case, because I was finding it difficult to find the celiac, to track it down, and just defatting all that area, I'll go find the right cruise, dissect the right cruise a bit, and then find the aorta, and then basically fill in the blank between the two. So that's how that's the other approach to it, not just going down from the left gastric, but then finding the aorta and then going down this way. So you basically use the two cardiacs and you split that right cruise. You don't have to disturb the hiatus. You don't have to do any of that. You just do a very limited tunnel here just to split the right cruise and find the wall of the aorta. Once you find the wall of the aorta, then all you're trying to do is to basically take all the tissue between your origin of your left gastric and hepatic into the aorta, and that will expose the entire artery for you longitudinally. So you can see really kind of being meticulous, using judicious moves, no big moves here. When you do the left gastric first approach, it's a lot quicker. The quickest I've done this case is about 27 minutes, and this is not a case that you want to rush. You still have to be very meticulous about it. I think the robotic platform has really enabled a few few surgeons who use this to do this operation more in a better fashion, and I'm sure this will help us improve outcomes in this difficult set of patients. And when you do the operation on the right patient that you've selected, it's a night and day difference. These patients really do well. They've been labeled crazy, and when they actually have a problem. So that in itself comes with some of the issues, and I think some of the patients have been unfairly bounced around. Imagine having a real problem and being told that it's all in your mind, and you go from ER to ER. And this is what happens to this set of patients and the gastrobariatrics. And you can see me kind of slowing down, trying to find all the fibers, doing an extensive lysis, and then you can see that artery coming into view, and now I'm basically taking the last few fibers that are compressing it, and then we can use ICG and fluorescent to check to make sure you've done an extensive release and there's no other fibers left there that need to be addressed. So you can see the entire view of the celiac artery, and you see the ICG being given, and you see the ICG lighting it up. And once you see that, you can see the entire origin is completely lit up. Sometimes you can, if you lose patients, I record all my cases, and I want to also show you the bad that I do. So here's a bunch of mistakes. I'm getting impatient because this patient had high visceral obesity, had a lot of fat around everything. The celiac artery was a meandering artery. I could not find, I basically am pulling with my left hand. You can see that quite extensively on the left gastric instead of using the loop. And now it caused some bleeding there. I'm like, okay, let me try and fix it. And basically using the robotic harmonic to defat that and see if that controls it. And I still have not learned my lesson. It's like I'm frustrated, so I'm pulling again on that left gastric. I wish I could blame it on someone else. This is me. So now I'm like, okay, let me just go ahead and take some sutures, try and repair that, and I'm making it worse. So you know how it is. Sometimes you're in surgery and you get into a hole and you can't get out of that hole. And now I'm like, okay, this is bad, right? So I've got it controlled now with some clips. It's left gastric artery. It's not a big deal. But look what I've done. What I'm doing in my frustration of not being able to expose, I'm actually using those clips to pull on it to expose it. And this is classically, so I'm finally finding the origin. I'm thinking that there's the celiac, but look at what my left hand is doing. You know, I'm like, how stupid can I be, right? So there's my left hand tugging on the clips that I just placed to get control of that of the left gastric artery. There. Now it's really twisted off. The clips won't close. I've got another proline here. There's a red out. Go back in. It's bleeding. And then I'm like desperately trying to control it. I'm just making it worse and worse. I'm really pissing it off right now. So now there's a Hail Mary clip that comes in. I got control. I was able to expose the artery. I went back to the CT, was able to trace it. It was a meandering artery. So in these kind of high intensity operations, make sure you record it, make sure you learn from your mistakes. And I'm an educator. I do the program for the National Body for American Society of Metabolic and Bariatric Surgery. I concentrate a lot on surgical mistakes, and how do we avoid it. And I think watching your videos and trying to process what you did, because in the heat of the moment, sometimes you just keep doing what you always do. So again, thank you all. Thank you for coming and visiting the city. I hope you'll have a good time and really get to enjoy Charleston along with this academic meeting. Thank you.
The question is, do you still have chest pain when you watch the video?
Yes, yes. It never goes away.